It is just a huge honor for me today to be podcast interviewing Dr. Robert Bryan, DDS, FACS, FACD, oral surgeon on the left. And that handsome dude on the right is the other oral surgeon, Dr. Jeremy C. Goodson, DDS. Wave, Jeremy. So basically, Robert grew up in Southern Ohio. After receiving a bachelor's degree at Ohio University, he earned a dental degree, scholarship award, and went on to attend a surgical residency to become an oral and maxillofacial surgeon. In 2006, he attended the University of Oklahoma for a 4-year oral surgery residency. He currently practices oral surgery at Mercy Health Center, Baptist Medical Center, and Oklahoma University Medical Center. Outside of the practice in local hospitals, he teaches at the University of Oklahoma Health Science Center. He likes to spend time with his wife, 2 kids, fishing, shooting firearms, and a new drone that he recently acquired. On his right, the Dr. Jeremy C. Goodson received his Bachelor of Science degree in Biochemistry in 2007 from Brigham Young University, and then continued to dental school at the University of Iowa College of Dentistry, achieving his DDS in 2011. He did his oral and maxillofacial surgery residency at University of Oklahoma College of Dentistry in Oklahoma City. Outside of practice, he enjoys spending quality time with his wife and kids, swimming, biking, and running. Dr. Goodson began taking lessons to learn to play the piano and trumpet when he was in kindergarten, and aspires to introduce the art of music to his children as they grow up. I had them come on the show because there's something is really on my mind. They basically, the press was all carrying that they're revolutionizing dentistry in Oklahoma with the first ever robot surgery. I posted this on Dental Town. You guys got the Yomi, and it's just the Yomi Robotic Implant, and it's just kind of interesting because there was a period of time where dentistry had no robots, and right now, and that time in Oklahoma was before you guys did one thing. You changed Oklahoma from the pre-robot to the now dentistry with the robot. And so I want to ask you, what made you want to bring a robot into your oral surgery practice?
Well, I think if you look at the history of our practice and you think of oral surgery specialists of Oklahoma, you automatically think of implants. And when we saw the robot, I think we recognized it as something that we really wanted to embrace in our practice because we actually believe that this is something that's going to make us better. I think it's a pretty revolutionary piece of equipment. There are other navigation devices that are on the market. This one's different. It offers something that others do not, and I think when we saw it, we recognized that. And there's a part of being a specialist and being an expert that obligates one, we believe, to embrace technology that we believe is actually going to make implant dentistry better. And we believe that that's what the Yomi robot offers. And so that's part of the reason that we wanted to have the robot as part of our practice and bring it into the state of Oklahoma for the very first time.
You said something very distinctive, that it was that Yomi was not just a navigation device. Is that the word you used?
That's correct.
Is that what you said? You said it was more than or you said there were other navigation devices?
Yeah, so this whole concept of navigation surgery and even robotic assisted surgery, it exists as you know, outside of the field of dentistry. And in the maxillofacial world or the neurosurgery world, the craniofacial world, there's navigation devices that have been used for a while, and I've done surgeries using those devices, and they're pretty amazing.
Can you name a company or a technique or a device?
I've worked with Stryker navigation and a few different surgical types, a few different types of surgeries. They're a little bit more unusual. That you probably you see one and you may never see that type of surgery again, kind of a frequency. So yeah, Stryker navigation. I don't know the names of other types of robots, but there's robotic surgery for other parts of the body, robotic prostate surgery, and
it's the Galileo they use.
Yeah. So, but the thing about the robot that's different than a navigation device. So, a navigation device basically can register the patient position and also the position of your instrument, and you look on a screen and you judge with your own eye am I where I am supposed to be? And the difference that the robot brings in is it has that plus another layer on top where we've input a 3D digital treatment plan into the software with the Comium CT scan, and we basically place the implant into the software program. And not only can we see where we're drilling in relation to that, but when we convert it into something called the guided mode, as we approach that position and that long axis of the implant, it will actually lock into place in the axis, so that as you're drilling through the depth of the implant placement, it will not deviate left, right, mesial, buccal, facial, distal, any direction. Only will allow you to go in and out, essentially. So it assists you in maintaining angulation, and it also provides a stop for depth. So there's quite a bit of control over position. So in addition to just verification on your own, it actually guides you on the position. You still move it. It doesn't move autonomously, but it basically locks you into a position. And so this concept exists outside of dentistry. Just in speaking with some orthopedic surgeons, I know that this type of technology exists in hip replacements and so forth, where it'll lock you into an exact angle. And so you can only move the instruments in that angle, and you get the cut exactly how you want. And so that's now come to dentistry and oral surgery. We have it for implants. So when we heard about that, we were on that, because this is a technology that takes us to a higher level. It offers the advantage too of over, for example, a surgical guide, where you plan something, you 3D print, or however you make your guide, you obtain the guide. And if you do your first drill, take out the guide, take a look at it, and you don't like the position, then you're left with freehanding it, which, as we know, can be very, very good, and is very good in many cases. But you no longer have any more guidance other than your own visual aid and landmarks. So nice thing about the Yomi is if you do your 3D plan and you insert that first drill and you say to yourself, you know what, I actually wish I would have planned that 1 degree more to the mesial. You just go back to the software, tweak it, it updates automatically. Your next drill, you're right in line with where you want to be. So it's this idea of live updating also that really takes it to another level. It's like, it would be analogous to saying, well, I didn't quite like that surgical guide. Let me 3D print another one real quick, and then you just all of a sudden have one. So it's pretty awesome.
So did you ever think when you were in oral surgery school that one day you would be doing this?
I think there are a lot of things that go through your mind when you're training as a resident. Probably this was not on our radar at that moment, but as you get into private practice, you begin to realize you don't know a lot, and it takes time. So you're actually continuing to learn throughout your career. And I think really when we started hearing about other medical specialties bringing robots into their practice, we certainly had some idea that would be part of our practice as it pertains to dental implants. We've always maintained such a strong interest in implants and implant dentistry, not only from a surgical perspective, but from a restorative perspective. We don't restore the implants, but we study that aspect of it, which helps us become better at placing them. So, when we see surgical guides come into play, we start seeing navigation come into play, and robots used in other specialties. We put 2 and 2 together pretty early on and really felt pretty strongly that it would be part of our practice at some point.
And where is robotic assisted surgery? Where did it land in medicine the most important? I mean, was it working next to the spine, the brain? I mean, I can imagine.
Sure.
I doubt it was a
Yeah.
podiatrist. Who had to have it first?
I think I'm not sure who had it first, but I hear a lot about robot-assisted prostate surgery, as Dr. Goodson mentioned, robot-assisted hip replacement surgery. So I think neurosurgery, of course, has been using guided surgery for some time now. That's an area of keen interest to all of us because mapping the brain out is, of course, very important. Knowing which areas are responsible for the problem at hand. So we're really following the lead of some of these other specialties that we work closely with to make sure that the technology we're using is good.
Well, I'm sure you paid a chunk of change in this. It was probably a six-figure investment. Would you mind saying how much something like this cost, or how much you paid for it?
Well, sure. I don't mind telling you. It was definitely six figures. I suppose from the company that sold it to us, from their perspective, perhaps the best way to go about that would be to check with them. I don't know how they do their pricing, but it's about what you might expect it to be.
So $100,000 or 150?
That's a pretty good ballpark.
100 grand?
Yeah.
And if you think that's a lot of money, you obviously haven't got divorced yet, because then you'll see what a seven-figure number is. But they always say, you guys are incredibly intelligent, well-schooled. If it's not broke, don't fix it. When you pay $100,000, what problem were you fixing? And the other reason I want to get you on the show so bad, well, number one, my Oklahoma dentist friends were telling me to get you on the show, but implants and clear aligners are the only double-digit growth in dentistry year after year for a decade. So when you look at, dentistry in the United States last year was $108 billion, but when you look at the globe, it's $500 billion. The United States got 211,000, but the globe has 2 million. And when you look at the 2 million dentists and their 10 million employees, the only parts of dentistry that are double-digit growth are implants and clear aligners. I'm sure you heard Smiles Drug Club and Invisalign and all that stuff. So looking at this this robust growth of implants, I want to ask you, why do you think implants is growing double digit? And what challenges do you see as implants are growing? And of those two things, what problem was a robot helping you? See, my style is I'll ask so many questions that maybe one of them's good enough to jump in on an answer.
Great question.
It's no problem. We have the robot on the other side of the camera keeping track of your questions for us, so it's not an issue. So I'll answer part of that. When you're asking what problem are we trying to solve, I'm not so sure we have to have that question deciphered before we embrace technology that we believe in. For example, if you were in Europe and someone invited you to get on their small wooden ship, back in the 1400s and sail across the ocean, that may not have seemed like a great idea to you at the time, but look what's come of it. And so I think when you consider yourself an expert, and I'll just with great humility say that I think that we are, as are my other colleagues, and you consider yourself pioneering, you have, as I mentioned earlier, I believe there's an obligation to embrace technology that you believe is going to make the specialty better, that you can find information, that you can gather information and use that to study. How good are we? How good can we be? So, I think from our perspective, I'm not so sure there was a specific problem that we were trying to solve. I think we recognize it as technology that's going to better our profession and make placement of dental implants better for our patients. So that's my answer.
Yeah, we really, both of us, Dr. Bryan and I both, we feel a passion and a responsibility to elevate the oral surgery profession. And there's a lot of oral surgeons doing that all around us. We're just happen to be two of them. And we're honored to be a part of that. So we want to be getting better all the time. We want to be learning more all the time. In fact, I've sort of always thought to myself that, I'll tell you, I learn something new almost every day. And I've thought to myself, if, the day that I stop learning, maybe that's the day I need to stop practicing. There's always something new to learn and always some way to improve. Now, so to speak to the question of what problems. The placement of dental implants, why is it so successful? I think because it works. It works so well.
Yeah.
The success rates of implants are so high. They are, and people like them. They love that they can chew. They love that they can have good cosmetics. There's so many long lists of reasons that they're so successful. And so how can we make them better? Because despite the fact that they're so successful, there are still challenges that are encountered by both the surgeon and the restorative dentist. And some of those challenges have to do with the position of the implant, the way it's put in, and how that influences how easy or hard it is to get a crown put onto it, or a bridge put onto it, or a denture, or whatever, what have you. And so some of those challenges with implant positioning, that's kind of what drove the whole idea of getting a surgical guide to guide the drill into the right position. Well, it's a great concept, and it works very well sometimes, but there's and studies have shown this, and my experience falls in line with these studies, that a surgical guide is not a fail-safe. It is not a close your eyes and drill. At the end of the day, the guide that's getting the implant in the right position is the surgeon, the eyes, and the hand, and the brain that think through the case and get it done right. And I think that I have found plenty of surgical guide cases where I've inserted the first drill or two and found that I needed to make adjustments, not because my plan was wrong, but because for whatever reason, sometimes, and there's various reasons, sometimes the guide will not position the drills where you planned it in your 3D planning setup. And so that's a fault. You asked what problem are we trying to fix? Well, once you get to that point, like I said, you're back to freehanding it. And then the studies show that surgical guides, they can have a range of error of degrees and millimeters. And when we live the implants, with implants, we live in a world of millimeters and degrees, fractions of millimeters, tenths of degrees. And so if you're off by a millimeter on a tooth that's 6 millimeters wide, that's a lot. So basically there's been a lot of efforts in the profession to improve our accuracy, and surgical guides were good. They are good, but they have limitations. They're not perfect.
Yeah.
And the other thing is, it blocks your ability to view the surgery a lot. There's a lot of visual issues with it. So whereas the robot, it's just the drill and the patient, like you would normally do the procedure. So it brings back visibility, so you can have instant visual feedback, and it also allows you to change it. So it just, in my opinion, it takes the problems with surgical guides and essentially wipes them away. So
yeah, I would agree. And then to address your question of the growth of dental implant industry, I think in an aging population where people value having their teeth more and more, that really speaks, I think, to a lot of the growth that we see in implants. We certainly wouldn't ever say a name, but we could go through the list of patients that we have in their mid to late 80s, early to mid 90s, that drive themselves to the office, have a consultation, make the decision that they would like to have a dental implant, and then proceed with the procedure, and then go on to use it for any number of years later. So I think that really is part of the reason why we're seeing such growth.
If you Google what is the success rate of dental implants, of course, WebMD comes up first because they're just big and they understand SEO. And right there in big letters, 98%. Success rates of dental implants have a 98% success rate. So I guess it just comes down to how do you measure success. I mean, you have other people saying that in 5 to 9 years, up to 40% of implants have peri-implantitis. How do you, I know how my patients determine success, because I might be really concerned about an implant. There's peri-implantitis around it. There's bone loss. but he has zero pain and he can eat a cheeseburger, and he's the happiest guy. So how do you define success of a dental implant?
It's funny you bring that up. I saw a lady yesterday in the office who had a dental implant placed probably 10 years ago. And if you ask her how she feels about it, she's going to say, I love it. In fact, I'm so happy that I have it. However, if you do an oral exam, you'll notice about 2 millimeters of titanium exposed on the lingual aspect of this implant. And it's a lower molar. The surrounding soft tissue is pink. It's not inflamed. There's really no probing depth. There's no mobility to the implant. It's completely asymptomatic. She loves it. In my mind, that implant is successful still. Maybe if you look from an academic standpoint, if you maybe were to look in a textbook, you may find a reason to argue with that point. I think if the patient is asymptomatic, if they're happy with it, if it's healthy, I think that's successful.
This is Dentistry Uncensored, so I don't want to talk about anything everyone agrees, and I like to go right to where the issues are. I know oral surgeons like you, 2 of them in the room, practice together, where one of them will place implants on smokers and the other one draws a line and says no. And in some offices, it's a few. It's like, well, if you're a smoker, well, you better go see the crazy man over there because he'll do it, but I won't do it. And so then back to the academics, they tell you what is the ideal case, and it's always Karen, your yoga instructor who's a vegan eating yogurt. But then when they show up in your office, oftentimes they're Billy Bob. And half of my cousins are from Oklahoma City. I was born and raised in Wichita, Kansas, so I've been to your neck of the woods. There's a lot of Oklahoma boys that chew and tobacco and everything they're not supposed to. So how does that affect your diagnosing and treatment plan?
Yeah, so as far as where do I draw the line, where does Dr. Bryan draw the line, what qualities make you good, the things we learn about in dental school and kind of the implant lectures and, as far as stratification of risk and so forth, I think they're pretty applicable to real life practice. You get someone with great bone, great soft tissue, great health, and, a non-cosmetic zone tooth. There's certainly going to be lower risk to that type of a case compared to changing only one variable, putting into the cosmetic zone. Even with great tissue and great bone, that's still a more difficult case. So adding in the layer of health, it's hard to make a blanket statement. I will say that I feel like treatment planning should be customized and tailored to specific patients. There's many patients who smoke that I have placed implants in, and they are just wildly successful implants. And so I see implants being successful in smokers. I see a little more bone grafting failures in smokers for sure. I think that's a little more troubling area. But there's just for example, a patient comes to mind. He came in for a consult recently. He had squamous cell carcinoma. He had radiation treatment. So the radiation in his oral pharynx was around 7,000 centigrades, and so and if you look at the radiation mapping in the areas of the mandible where the teeth would be present that he needs to have removed, there's it exceeds 5,000. And on top of that, he smokes 2 packs of cigarettes a day. So he's already got compromised vascularity from radiation treatment. And now we have additional vascular disease from the smoking. So that's different than someone who smokes 1 pack a day and is, I'll say otherwise healthy. If you smoke, there's obviously some health problems that are going on if you know about it or not. But so I guess don't know if I answered your question clearly, but I think that it needs to be customized. And there's patients where I have not done it, who smoke, and there's patients where I have done it and it's been very successful. So it's hard to draw just a really strong line in the sand there. I think all the variables need to be taken into consideration. Something that we see a lot of is diabetes. There's a lot of patients who have diabetes these days. And so, those type of health problems come into play for sure. If they're not going to heal well, and they don't have good blood flow, then, there may be problems healing that implant.
So more dentistry uncensored issues. You're added a robot assisted to CBCT, right? Well,
Correct.
A lot of people are still placing implants with panos and saying, dude, I placed 5,000 implants with a pano. And then some of the lawyers are in the middle saying, well, a CBCT is now standard of care, while other dental attorneys on Dental Town say, man, if you ever figure out the definition of standard of care, please let me know. So I'm going to just ask you the impossible question. Is CBCT the standard of care in placing implants?
I'll answer it like this, and I get this line from my good friend here, Dr. Goodson. There's rarely a time when I wish I had less information. And if I'm the patient, there's rarely a time when I want my surgeon to have less information about me. There's rarely a time when I would want my surgeon to be a little more unclear as to where my nerve is, or the sinus is, or an adjacent tooth is. Perhaps an important thing to note would be how wide is the bone? How tall is the bone? What are the real angulations of the teeth? Because you do get distortion on a flat X-ray. So I would venture to say that, in my personal opinion, I think a cone beam is the standard of care. If I'm getting a dental implant, I'm getting a cone beam.
Okay, and when we look at these big technology decisions, one of the biggest issues the young millennials are having is there's open format systems and there's closed format systems. I mean, like Apple, I have an iPhone, but it's a totally closed system, and Android's open. Is Yomi agnostic to CBCT and work with any? Is it a closed system that works mostly with one?
I think the biggest issue to conquer there is field of view. So the system is open. I would call it open.
Yeah.
And the question that you have to answer here is the field of view that your cone beam CT scanner is able to capture, is that large enough to give the robot computer all of the information that it needs to adequately mark, treatment plan, and execute what you're trying to accomplish? As far as openness to other dental implant systems, as far as the brands are concerned, there's full openness there as well. So I think it's less important from a manufacturer brand perspective as do you have the information that's available to accomplish the surgery?
Well, that was the perfect segue for my next question. I always get dental students, they're always saying on Dental Town or emailing me saying that I feel like I need to know which implant system to buy first, because when I look at all the available training and programs for implants, whether it's placing, restoring, whatever, they're all most of them are provided by the dental manufacturer. So they're like, do you need to choose an implant system before? Then the other people are saying, well, when you took driver's ed, it didn't matter what car you used from driver's ed. You applied it to the car you bought. So she's 25 years old. She just walked out of dental school. And I know her only question is, what implant do you use?
Yeah, there are a lot of implant systems out there. I mean, more than I could actually number, probably. So
it passed 400 now.
Okay, I that's good to know. I was actually wondering. So I'll just tell you what I do, and maybe that'll be helpful. So, the predominant implants that Dr. Bryan and I place in our practice, we place a lot of Straumann implants, we place a lot of Nobel implants. And I will say this, one important lesson that I've learned that I think pertains to the subject you're addressing is the concept of, we can't fall into the trap of thinking that there's one implant that will meet all indications across the board. Again, I come back to the idea that we have to be customized in our treatment planning. There's cases where I've felt like, okay, well, for example, most often I'll place a bone level implant, and then we have full control of shaping the soft tissues and the transition zones however we like with the prosthetics. But there's still cases where I've, even today in the world of, where all we do here, it feels like, is tissue shaping, which is a good thing. Where I've placed tissue level implants because it's been indicated and it's been better. So I would say to start with something and try to gain an understanding of the restorative aspects of the care, and then what parts of the implant system influence those restorative aspects, and then you'll be able to make a decision. Yeah. So the basic concept of most of the implant systems are fairly similar, as far as the surgical side of it. There's, a series of drills, and the implant designs, differ somewhat. But, if for example, if you've got someone with a very, very porous bone where you won't get a whole lot of high insertion torque, well, that's a case where I want to have a little bit more engaging thread design, or else I may not get primary stability. And there's cases where you just need a wider or a skinnier implant, to fit or to make the transition zones correct in their shape. And so I'll kind of go. That's kind of why I feel like I have both of those systems available to me, and I feel like they're both very user friendly in terms of restorative aspects and the surgical aspects. So. Does that help? Does that answer the question at all?
Yeah, that does. So what was it? I don't want to be too personal, but what was it like working with the company that makes this? It's called Neosys, and
Sure.
It's founded by an Alan Moses, a PhD. How has your expectations and everything matched up with this guy?
Well, I'll give you a little background in how we got started with this. Is I was approached by the company on LinkedIn. LinkedIn is somewhere I have spent quite a bit of time over the past several years building a network. And when I was approached by the representative, I recognized it as something that we were interested in, and so I kind of took the bait, I guess, so to speak. And they were really moving forward from that point, just super incredible. The gentleman that I speak of drove up from Dallas just a number of times. That's a 3-hour drive to not only tell us about the robot, but they took it a step further. The company actually has traveling buses that contain the actual robot. And so they drove the robot to our office and allowed us to actually use it on a typodont. And so, that was a big selling point for us. We really felt like, giving us an opportunity to use it and see it in action was very important. And moving forward from there, the installation was great. They bring the robot to the office. They spend an entire day setting it up, calibrating it. There's a lot of work that goes into that in advance, even of that visit, making sure that you have the infrastructure and IT capabilities to manage, the software and the robot itself, not only from a hardware but software perspective. Then they spent a few days here training us on it, and really, if I were to grade the company on their responsiveness to our needs, I would say an A.
Wow. On Dental Town, there's a case where a prosthodontist bought Yomi for his surgeons to use in placing them. I thought that was a very interesting. He just restores. He doesn't place. but he bought Yomi for his own surgeons to use.
Yeah, if you could just forward his name and number to us, we'll be getting a contact with him just as soon as possible.
So has that crossed your mind?
It hasn't. As far as someone purchasing it for us or us purchasing it for someone else, I mean, we have great relationships with our restorative colleagues, with our periodontal colleagues, orthodontic colleagues, other oral surgery colleagues here in Oklahoma City, and some other states as well. We see a lot of people from out of state coming in from Texas and Kansas and other places. So we really are about relationships. That's really important for our practice. When we're thinking about a technology that's new like this, and one that, as I mentioned in a previous program, I called it pioneering. That's something that we feel we have a great responsibility for in handling it the right way, not only for ourselves, but for our patients and for our staff members. We think that we have an obligation to handle in a certain way, even as it pertains to the manufacturer, because we really want to be a good team. And so, from our perspective, we really like to be kind of in control of that so that we know that we're making really good choices for our patients.
So this is Dentistry Uncensored, so I don't pull any punches. I go right to the most controversial stuff. Good luck with this one, gentlemen. When you look around the world, the anesthesiologists, the epidemiologists have said that anesthesia needs to be a specialty, and no longer in many countries are you allowed to go in the hospital and do the sedation while you're doing whatever surgery. They've separated that. And some countries, England recently, they told your profession that you guys can't do it anymore either. When you're in the United States, when you're in Oklahoma, for example, in all the hospitals, I'm certain you have to have an anesthesiologist do this and a surgeon do this. It seems like only dentistry is the last place where the surgeon is doing the anesthesia. Do you think that it'll still be that way in 10, 20, 100 years moving forward? Do you think that will come to an end? What are your thoughts on that anomaly?
Sure.
That
I suppose there's several different things that would need to be considered when answering this question. But sometimes I give sort of subjective answers. My good friend here gives very objective answers a lot of times. From a subjective standpoint, I don't feel the momentum or the pressure of that worry here in Oklahoma. I don't have people calling me with concerns related to that. I also think if you look at AAOMS, if you look at oral and maxillofacial surgery in general, the history of our specialty, and the current mechanisms and parameters of care that we have in place, I think we have a really good track record, and I think it speaks for itself.
would you, just like Yomi Robotic Assisted Surgery didn't exist when I got out of school. Now it does. Do you feel the momentum is that anesthesia is getting safer and higher tech than, say, it was 20 years ago, 30 years ago?
Well, certainly the types of medications that we use are always changing. And so, one of the problems with maybe previous medications that we would use would have to do with active metabolites and half-life and all that stuff. So a lot of the things that we use now are I'll term it cleaner. They're short-acting. They're reversible a lot of times. And in addition, as I mentioned, I think as an oral and maxillofacial surgeon, we just have such a depth of training and a comfort level with those. But I think as important, we have a very, very deep respect for what it means to be able to do the things that we do. We understand and feel. You talk about feeling something, the momentum. What I think we really feel as it pertains to this topic is the gravity of that topic, of the need for safety. We also feel the need for redundancy. You get onto an airplane and the number of redundant mechanisms that are in place to make that safe I can't even imagine what the number is, but I know that it exists many-fold. And the same thing exists in our practice of anesthesia and surgery in the private setting for oral and maxillofacial surgery. We do have a checklist. We have 3 people in the room at all times. We have great monitors. We have people that are on our team that are super smart and talented, that care about our patients, and they too feel the gravity of that. And so that, combined with our experience, combined with the wonderful medications that we have and the equipment that we have. In fact, we just purchased recently a glide scope. So a glide scope is an airway mechanism. It's a video, actually, type of laryngoscope that gives us even greater views of the airway. So, we not only invest in the things that we think that we need, we also invest in the things that we hope we never need, and that's one of them.
Did Michael Jackson ruin the brand name of Propofol?
I
was having a beer with an oral surgeon, and he's not very happy with Michael Jackson because every time he says the drug, it opens it.
Sure. Well, I'll just tell you, it's kind of, so I've actually, believe it or not, had a lot of patients ask me, am I going to get what Michael Jackson got?
Mm-hmm. Yeah.
And the drug that he received, propofol, is one of the workhorses of anesthesia in the oral surgery world. And so, of course, the answer is, depending on the case and health criteria permitting, yes. And so my answer to that patient will be yes, but the big difference is you're going to have somebody monitoring you. And I wasn't there. Okay. I wasn't there when that happened with Michael Jackson. I'm just talking about what I've read from news stories and that sort of thing. But my understanding was that there was the monitoring was not in place, and that was the problem.
Yeah.
And so the problem was not the drug itself, but the lack of monitoring. And so I think to speak to Dr. Bryan's point about monitoring, there is a lot of monitoring that goes on. I mean, there's standards of care. I'm not just talking about, we monitor it because it feels good or it sounds good. There's actually standards of care that we meet to make sure the patient's safe. And
okay, so on that note, you walked into a perfect segue. A big issue of mine for 32 years is that you guys are oral surgeons. You're not general dentists. You have all this training. You just bought this new scope, all these things. And then in the hospitals, they separate the anesthesiologist with the surgery. And then my homies, they go take a weekend course at Docs, and they want to start doing sedation. And then when my friends in dental malpractice, and they send me the reviews of their settlements for the year or this or that, whenever it's $1 million, $2 million, $3 million, they all have the same thing in common: sedation. Someone died. So what would you say to a general dentist, and she's 25, and she thinks that she's going to add sedation to her repertoire because she thinks that'd be a good marketing decision? People will come in and want to have sleep dentistry.
Yeah, it's very alluring, and there's a lot of people who want it. And so I can understand the draw for that and the want for that. And I really can feel that. I really can. And I think that, and I don't have data to back this up, but I know there are a lot of general dentists who offer that to some level of sedation. And the safety record numbers I wouldn't be able to quote to you, but as I learned in my training, I would say to those dentists the same thing that was taught to me, which is in the world of anesthesia and surgery and really dentistry, you have to be prepared to handle the worst case scenario. And so if your training is in a level of anesthesia that is very light and conscious sedation, that's fine, but you need to have skill level to be able to handle deeper levels of sedation and general anesthesia. and advanced airway techniques, because anyone that provides anesthesia can tell you that you can't always predict a patient's response to a drug. You can titrate, you can have a reasonable expectation of what they may have, but ultimately you judge the patient's response based upon subjective viewing, but also objective data from the monitors. And so you have to, if you're going to implement it in your practice, you have to be confident that you can handle worst case scenarios. And I'm talking about things like Dr. Bryan brought up the laryngoscope. Ask yourself the question, do I feel comfortable intubating someone?
Would Joan Rivers have been better served if her doctor had what you just bought?
Hard to answer that question given our limited knowledge of that particular case.
It was a laryngospasm, wasn't it?
That's my understanding. That's my understanding. Yeah, and I think that the glide scope probably would have been probably helpful in that case. But there's also the idea of recognition that's important in anesthesia. So early detection of problems is really a big issue, and that comes with experience in many cases. And so it's difficult for us to be overly critical of things that have happened, but it's easy for us to speak to the idea of being well trained in understanding.
Well, you guys are class act gentlemen, and I love you for it, but I'll just be a little more blunt. It's a bad idea. Don't put an IV in someone's arm. And if you ever talk to an attorney who just finished a case, do you know what you look like on the witness stand when they bring in some PhD, MD anesthesiologist and starts cross-examining you on the witness stand, and there's a dead person that they're talking about? I mean, it's just, God, it's a bad idea. It's just a really bad idea.
That's the gravity of what I mentioned earlier, and we think about those things oftentimes, and we're put into a strange position as oral and maxillofacial surgeons, just by nature, and so kind of navigating the labyrinth of these issues is something that we can kind of deal with on a daily basis. I can say this about it. I feel really good having the training that we have and the level of experience that we have. I also feel really good just being in live situations during those training years where things happened that required us to act in those ways and actually do those things in real life. That's very hard to simulate. It's very difficult to simulate. So I think, we're just really thankful that we have the training that we do.
I'm so honored that you guys, after a long day at work, decided to hang out with me and my homies. I'm trying to wrap this up real quick. Just hitting all the controversial buttons I can. Temporomandibular joint surgery, replacing custom joints. You got to remember when I got to school in '87, they had that big issue at LSU where they were putting in artificial joints and they were falling apart. Is temporomandibular joint surgery getting better? Is it a growing part of the solution of TMJ issues? Is custom joint replacements growing, or is it shrinking? What would be the update as we're going into 2020? So hopefully at 2020, I'm hoping everyone will be able to see more clearly at 2020. How does TMJ joint surgery and joint replacement look different today than, say, 10 years ago or 20 years ago?
I think, I'll answer it like this. The custom joint replacement surgery, I would say, is better now, given the high definition CTs that we have, the CAD/CAM capabilities that we have, the material science that we have. So from a, I guess, quality standpoint, I would argue that custom made temporomandibular joint replacement is better now than it was. several years ago. I would also add that we're learning more and more about conservative therapy. We do an awful lot of arthrocentesis in our practice. There are a lot of people that have problematic joints that don't necessarily need a surgery. And so oftentimes we can do something fairly conservative, like an arthrocentesis with some physical therapy that will take care of a lot of the problems. There's also the issue of
what's the word you're saying? Spell it for me.
Arthrocentesis. And so that's basically a procedure that we have these featured on our Facebook page, actually, where you put a couple of ports into the joint, the encapsulated joint space. One's an inlet, one is an outlet. Flush fluid through it, deposit any number of things, sometimes steroids, local anesthetic, sometimes PRF.
Interesting. Is that is TMJ surgery a big part of a practice, or is it more a rare thing?
Well, we certainly see a fair number of TMJ patients. The types of TMJ procedures we're doing are definitely a lot more on this conservative end. I like how you brought up, so I'm going to tie this into a question you asked earlier. You brought up the idea of anesthesia and training, and we can throw in implants or any number of things in there. But as far as being able to perform a procedure really well, that's something where you'd want to have a lot of experience. So you talk about anesthesia. If you've had months and months of experience and hundreds of cases, that's experience. So that gives you knowledge, and it gives you intuition. And so if you look at an oral and maxillofacial surgeon that's doing total joint replacements for the temporomandibular joint on a regular basis, there's going to be some experience and training and understanding that they have that someone who does it very infrequently just wouldn't have. And so it's really for that reason for me that I don't do total joint replacements in temporomandibular joint. I certainly learned about them in my residency and participated in those surgeries. And I could have chosen to go that direction more. But there's such a broad scope in the world of oral and maxillofacial surgery, and it's difficult to get a sense of expertise in everything. And so, if you really want to become an expert, you end up doing a little bit better job if you narrow your scope just a little bit. So, I say that, but I do see a fair number of TMJ patients. I probably see TMJ patients every week. But I'll say that there's a lot of success that we have with conservative measures. And then, occasionally identify a case that needs something more invasive, and we're able to help get the patient, what they need.
I'll say this too about it is, I think dentistry in general would do itself a favor to keep this in mind. You can be an expert in a few things, or you can be mediocre at a lot of things. And to speak to Dr. Goodson's point, we just choose to limit our practice to those things that we think we're really, really good at.
And the other thing I want to tell you kids is that you can't fight centuries of macroeconomics. So in 1900, healthcare was 1% of the GDP, no specialists. At the end of the century, 2000, it was 14% of the GDP. The physicians had 58 specialties. We had 9. Now it's 2020. Healthcare is 17% of the GDP, and we just added another specialty. So the trend is that there's so much information that everybody is specializing. They're specializing in economics. They're specializing everywhere. And there's just no way in the world we're going back to 1900 with a super doctor that's going to do a root canal, place your implant, do a bone graft, treat your screaming 3-year-old. I mean, that's just not where we're going. We're going, and you said it earlier, you said there's rarely a time when you want less information. Well, you can structurally have almost no information if you want to be a jack of all trades. And I just don't see successful people being an expert in everything. Just two more controversial questions. I'll let you go. I know it's the end of your day and you're tired. We have millennials now. They have access to a lot of information. So they're coming in, and they're my friends in Phoenix here. They're where the doctor says, "Yeah, we circumcise all baby boys." They're saying, well, "Hey, slow down, slow down." We remove wisdom teeth. Slow down, slow down. So you're having a generation that has self-esteem, access to information, and they just don't believe in that every male born should be circumcised and have his wisdom teeth pulled out. Are you feeling this generational pushback where people are challenging this diagnosis that I need to have my wisdom teeth taken out prophylactically at 17, 18 years of age for something that might go wrong when I'm grandma and grandpa?
Yeah, I would refer back to an earlier comment I made about AAOMS. They've put out a nice white paper on this. I think it speaks for itself as far as the evidence goes to support the removal of wisdom teeth. And I'll say this about millennials. First of all, we love millennials. It's really awesome and stimulating to sit down with somebody who has access to information, because then you can have a conversation with them about what are the risks, benefits, and alternatives. Paternal medicine is over. There is no such thing as paternal medicine now. It is, what are my options? First of all, what's the diagnosis? Secondly, what are the treatment options? Then what are the risks, benefits, and alternatives? And now let's have a discussion about that. The other thing I love about millennials is we can reach them very easily. We just have to get inside their cell phone. And so Facebook makes that really easy for us to do. Google makes that really easy for us to do. I mean, you could go on and on and on. Dental Town, I guess, makes it easy for us to do. And so I think it's exciting. I love taking a segue here. I apologize, but I love the marketing aspect of what that offers for our practice. And it's all about connecting and forming relationships with people, and such as yourself, even, and people that are in other countries. We have conversations routinely with people that are in other countries, that certainly are in other states, all the way across the country. And it's stimulating, it's exciting. And I think just like this robot, we embrace that. We're looking forward to more of that. So I hope that answers your question.
Yeah, it does. That is a thanks for bringing up that paper. I'll post that as soon as we're done. Let's see. I had what was my did I have a? Oh yeah. Orthognathic surgery. You work with orthodontists. Would you say that orthodontists are using orthognathic surgery at the same rate they did 10, 20, 30 years ago? Is it a procedure that's going to the wayside? Is it making a comeback? Well, give us an update on orthognathic surgery as opposed to a decade or two ago.
Well, as far as the number of people using it, there's a lot, because it keeps us busy. And orthognathic surgery is something that we both feel passionate about and we love to do. And so that's an area we've chosen to include in our practice because we like it and we feel like we can do it well. So as far as how has the trend changed to 20 years ago? I'm not sure I'd be the best person to answer that trend type question. I'll tell you, there's a lot of orthodontists we work with, and they tend to be very good at identifying the problem and how to correct the problem, and recognizing when something beyond traditional orthodontics is needed to help correct the problem, namely surgery. Now, even when that is recognized, it doesn't mean that the patient automatically then wants to have surgery. So they also have to be good at coming up with alternative ideas. And so, there's your plan A and your plan B. And so, sometimes patients accept it, sometimes they don't, and you go with the plan B. But I can tell you so orthognathic surgery, just like dental implants and Yomi, orthognathic surgery is changing in terms of how precise we can get in our planning and our execution. So you didn't ask this question, but let me answer this question just because it's it fits with this whole topic of robotics and virtual planning. So for many years, orthognathic surgery was it was planned with impressions and models and in your lab and your articulator and your model surgery that you cut the stone models and you make your splints out of your polymethyl methacrylates and that sort of thing, and that's very good. That's very good, and it gets good results. And so why change it? Well, because there's ways to make it better. And so nowadays we have ways where we can do all of those things I just said virtually. So you take impressions, you get some models, you get 3D files of those models, and you merge them in with the patient's CT scan, and then using software, you virtually perform the surgery. You set the jaws where they should be, and then using 3D printing, you create splints that in the surgery fit the upper and lower teeth and position the jaws exactly where you positioned them in your 3D planning, your preoperative planning. And so the level of accuracy we have it far exceeds what we used to have 10 or 20 years ago. So that's an area where it's really changing. And so especially speaking of millennials, technology speaks to them because they were raised with it. And so, I get people at church or people on my street coming up and saying, "Hey, I saw your videos about your 3D planning for jaw surgery. That's so cool. I mean, that's amazing. I had, and then their parents will say, I had that surgery when I was younger. I wish I would have had, the ability to do virtual planning. That was just so cool." And I'll tell you, there's cases where they're super straightforward and you could totally easily accomplish them with the old methods. But there's cases where there's subtle asymmetries or little changes where, gosh, without this 3D planning and ability to just fully control it, it'd be tough to get it right. And so, this whole idea of 3D scanning, virtual software, robotics, all that plays really well into orthognathic surgery. Orthognathic surgery is changing. The world of it is changing. We're able to do the surgeries more accurately. We're able to do the surgeries faster now than they used to be done years and years ago. The hospital stays are shorter. 10 or 20 years ago, maybe they were wired shut. They're not wired shut anymore. So stuff is changing. It's a lot more accessible to patients.
Yeah. I think to speak to your question of is orthognathic surgery a growing thing, logically speaking, just from my perspective, when I look at companies investing what I believe to be a great deal of money in coming up with virtual surgical planning software and techniques, it's an indication to me that it's a growing practice. And when I look at our own practice and the number of cases that we do, it blows me away how busy we are with it. And we just kind of revel in it and think it's wonderful. It's kind of like dental implants. Dental implants work. We know they work. That's why we love doing them. That's why it's so easy for us to talk to people about them. Jaw surgery works, and the results are incredible. It's so easy for us to sit down with the patient and recommend it because we know it's the right thing, and it works.
Well, I'm sure at the end of the day, you guys wanted to go home and have supper with your family and kids, and it was just an honor and a privilege to have you join us after work today and talk to my homies about all things oral surgery. Thank you so much for spending an hour with us after work, and I hope the rest of the evening goes well.
Likewise, thank you, and we look forward to coming back and visiting with you.
Hey, if you ever want to come back and talk again, come back and talk again. We'd love it. That's fantastic.
You bet.
Okay.
Thank you so much.
Have a good evening.
Thank you.